Can you hear me? Okay, I will try to cancel. Okay. Okay, great. So let's start. So, moving on in a little bit in endocrinology, the next topic we are going to speak about, we need to move on a little bit with the pathology. So today we are going to speak about a really important topic, which is hypo and hyperthyroidism. This condition you can see everywhere. You can see in some family members, you can see around us. It has so many causes. We'll speak about some of them today. And most importantly, I want you to be able to know that if that patient truly has hypo or hyperthyroidism or not, and which symptoms he will have. Let's start with the hypothyroidism. Patient with hypothyroidism will have cold intolerance. Let's try to understand why. Well, in case of hyperthyroidism, the thyroid hormone works as an uncoupler. What does mean uncoupler? Uncoupling agent are basically agents that prevent the oxidative phosphorylation to occur. So, if you remember what I'm speaking about, there is something called electron transport chain, something we did not explain yet. But electron transport chain, yeah, this thing. So, there is a few things that are called uncoupler, which prevent the ATP from being made. Such uncoupler include thyroxine, which is the thyroid hormone, also aspirin overdose, 2,3-dentrophenol, which is a drug used for weight loss. Basically, we will have less ATP making and more heat creation. So the more heat you have, the less ATP you will be creating, and thus you will be losing weight. So people with hyperthyroidism will be losing weight. Why? Because thyroxine works as a uncoupling agent. Okay? Okay, so let's go back to that page. Nice. So the next thing I want you to know, yes. Okay, so if that uncoupler is not being able to work, what we will have? So heat intolerance and increases sweating. If it's working too much, basically, you will become really hot. Also, you will lose plenty of weight. It's not only because it works as an uncoupling agent, so more ATP in hyper. Not really. It's. I will show you what happens. So basically, in that case, you will have less ATP, more heat. Okay. So the patient is going to be, well, utilizing all of his glucose to make heat. If he's making a lot of heat, he will be sweating. Yes? And he always will be like, doctor, I cannot sleep because I feel so hot. I turn on the AC, I am like sleeping naked, but I still feel hot. So what's up with her or him? The answer is hyperthyroidism. Okay? Heat intolerance. The weight loss. Why the weight loss occur? Guys, I hope you remember about something called the sodium potassium ATPase. Which drug works here, by the way? At the sodium potassium ATPase, there was a drug that used to work there. Which drug was it? Yes, it's digoxin. So digoxin used to work there, and it used to lead to basically increase in the contractility. So yeah, so there will be more synthesis of this pump. This pump consumes a lot of ATP. So if you consume a lot of ATP, are you going to get weight gain or weight loss if you have more of these pumps? Yep, absolutely. If you have much more of these pumps, see, instead of one, you have like, I don't know, 6 of them. So you originally had 1, now you have 6. So you are going to consume more ATP. If you consume more ATP, what is going to happen to your basal metabolic rate? Yep, it will be up, which means there will be more expenditure of it. So increase in the basal metabolic rate and basically more calorigenesis. Okay, so we'll be burning all of these calories really, really quick. Let's take a look at hypothyroidism. So cold intolerance decreases sweating, weight gain, decreased basal metabolic rate, and also hyponatremia, which is due to a decreased free water clearance. Less water will be cleared out of the body, which is going basically to lead to hyponatremia because there will be more water inside of our body. We will learn later how is that related to something called edema and why the edema happens and its relationship to something called the glycoaminoglycans. But just give it some time. Okay, so let's speak about the skin and the hair in case of hypothyroidism. So in hypothyroidism, we'll have a dry, cool skin. Why? Because we have less blood flow to the areas, peripheral areas. Also, you can have a coarse, brittle hair. I want you to see how a brittle hair looks like because this is commonly asked, not only in the exam, but actually in real life. A lot of ladies come to you and they are like, doctor, my hair used to be fine and beautiful, which is on the right, and now it becomes really, really brittle. What's up with me, doctor? See the ending of the hair. You are like, well, it can have multiple etiologies. One of them is hypothyroidism, but it's not the only one. Also, some ladies can have it because of fungi. Some ladies can have it because of weather. Can the weather lead to changes in the hair? Yes or no? Yep, absolutely, it can lead. Also, I forgot how the hair dryer. Yes, you know this hair dryer also, it can it lead to brittle hair dryer. If you use it excessively, the answer is yes, it can lead to it. Okay? Okay. Nice. So that's a brittle hair. Also, diffuse alopecia. Alopecia is no hair, okay? And the brittle nail. Please be careful when discussing the brittle nail because they kind of look like psoriasis. Just a second, I need to make sure I'm recording. Yes, I am. So, brittle nail in hypothyroidism. Yep. So, let me find the correct one. Yes. Can you see they get like destroyed really, really easily? But actually they look much worse than this. Just a second. Oh yeah, kind of like this guy or even this guy. Yes, this guy is just, yeah, this is the typical hypothyroidism type of thing. Okay, so their nails will be destroyed basically. Okay, so the next thing we have is puffy faces and generalized non-pitting edema. The mixed edema is due to an increase in the glycoaminoglycans in the interstitial spaces, which increases the osmotic pressure inside of your body, which eventually is going to lead to water retention. Okay, so what is this glycoaminoglycan? Glycoaminoglycan is a chemical substance made out of sugar and proteins that can deposit in some portion inside of your body, and it's osmotically active, which means it sucks a lot of water, so the amount of water inside of your body is going to increase. Okay, so the next thing we have here about hypothyroidism is ocular. So ocular stuff, just a second, you can see here the mixed edema. And guys, is it pitting or a non-pitting edema? It's a non-pitting edema, that's correct, non-pitting edema. Which other edema is a non-pitting edema? Come on. Yes, the other non-pitting edema is lymphedema. Lymphedema. Okay. So they write here, ocular, yes, these patients also can have this babble edema, sorry, periorbital edema, not babble edema. Babble edema is something else, intracranial hypertension. So yeah, that's also periorbital edema. Okay, so gastrointestinal, patient can have constipation, which decreases the GI motility and decreased appetite. So yeah, the patient can have constipation and because of less motility of the GI and also less appetite. Good. What musculoskeletal abnormalities they will have? They can have myopathy. This is important. Why? Because they will have specific symptoms here. So proximal muscle weakness, and this proximal muscle weakness is associated with an increased creatine kinase, which is something not seen in hyperthyroidism. So let's speak about the proximal muscle weakness. Some symptoms of proximal muscle weakness include inability to sit up from the chair. Okay, so somebody is sitting on the chair, but she or he cannot stand up from the chair. Also, one more thing is inability to comb the hair and also inability to reach a high shelf. Okay, they do mention these things: inability to reach high shelf, inability to comb the hair, inability to stand from a chair. Okay, so also they can have carpal tunnel syndrome. How come? Because they will have accumulation of glycoaminoglycan within the carpal tunnel. And does anybody remember which nerve is located within the carpal tunnel? No, it's not the brachial. It is the median nerve, nervus medianus. So this is the median nerve. And when we have accumulation of glycoaminoglycans here, it's going to lead to neuropathy. Okay. So, mixed edema. So a small lump rising on the surface of the muscle when stuck with a hammer. So yeah, when you this is actually kind of interesting finding. When you hit it with a hammer, I mean the skin is going to create a lump, you know, which is like a rising in the skin. This is characteristic of mixed edema. Reproductive. They can have an abnormal uterine bleeding and decreased libido. Libido is the sexual desire, of course. And also they can become infertile. There are some things you need to check before when a lady comes to you and she's infertile. We do check the FSH, LH, progesterone, testosterone, estrogen, and thyroxine. TSH. Okay? This is the test that we do generally. And GnRH. Okay, so neuropsychiatric stuff. Well, you have hypothyroidism. So everything is going to be low. So you are going to be hypoactive, lethargic, fatigued, weak, and this is the most important one, depressed mood. Can you tell me which vitamin deficiency can lead to depression? Actually, the vitamin deficiency that can lead to depression is vitamin D. Excellent. Vitamin D. That's why which countries have really good quality of life, but they have high suicide rate? Absolutely correct. Scandinavian countries. So Scandinavian countries tend to have really good quality of life, you know. They have money, they have like good way of living, but still high suicide rate. Why? Because no sun, no vitamin D. No vitamin D, you got yourself a problema. So they try to educate them at young age to start doing start consuming vitamin D. Okay, so the next thing we have here is, let's see, yeah, you can see that we have neuropsychiatric stuff, all of this, including the depression. Also, the reflexes will be delayed, okay? And with a slow relaxation, I mean they contract, but they cannot relax. The cardiovascular abnormality that can occur in this patient, everything is low, so they can get bradycardia and dyspnea on exertion. Why dyspnea on exertion? Because bradycardia is eventually going to reduce the cardiac output. Also because they have less contractility, yeah? Remember guys, the thyroxine help you to put more bombs, sodium potassium bomb, on the cardiomyocyte, which means more contraction. So when it is low, you have less contraction because less sodium potassium pump. Okay, somebody has primary hypothyroidism. So primary hypothyroidism, which means the problem is inside of the thyroid itself. That means the TSH is going to be high, while the free T3 and the T4 are going to get low. Guys, if you get an exam question and they tell you some patient with any thyroid problem, what is the first hormone to check? Is it T3, T4, or TSH? Well, the correct answer is TSH, absolutely. TSH is much more specific than T3, T4 because they can be false positive or false negative, you know? So but the one that does not lie is TSH because it does not bind to anything. But the T3, T4 requires a transporter to be bound on in the periphery. Okay, we have hypercholesterolemia, which is the next thing. It's due to a decrease in the LDL receptor expression. Okay, so less LDL receptor expression, that means less uptake of the LDL, so less clearance of the LDL, that means hypercholesterolemia. Yep. So now the hyperthyroidism. Of course, they will feel warm and moist skin they will have due to the vasodilatation, fine hair, and onycholysis. Let's take a look at onycholysis. Okay, can you see this oil-like stain? It's like he dropped oil on his hand or something on his fingers. Yeah? Yep. So this is a sign of hyperthyroidism. Do not confuse it with the brittle nails, which exist in case of hypothyroidism. Okay, let's keep going, and hopefully, like during the next class, I will be explaining to you the different types of nail pathologies. Speaking about the clubbing, iron deficiency with the like onycholysis. Sorry, not the onycholysis, but the spooning of the nail. And we will speak about onycholysis, we'll speak about the brittle nail, we'll speak also about a problemo that occurs in the nail, which is psoriasis. So I will help you to take a look at the nail and be able to know what it is. So pretibial myxedema and Graves' disease also can happen. Okay, let's keep going. So ocular stuff. So the ocular stuff in this patient, you can have, well, you already have hyperthyroidism. This can lead to an ophthalmopathy and Graves' disease. Why? So this is the eyeball, and this is like the cornea. And behind the eye, there is this fibrous tissue and the fat, okay? It will be important in a second. So, including periorbital edema and exophthalmos. Lid-like retraction and we'll speak about it in a second. So, let's try to understand why people with the Graves' disease have exophthalmos, which is, I hope you know what exophthalmos is. It's basically when the eye like becomes outside of the orbita. Exophthalmos. Yeah, so you can see his eyes is basically outside. So how can you take a look at the patient and be like, well, this patient has exophthalmos or this patient eyes is big, you know? I will teach you a trick. If you take a look at an eye, should it be like this or like this? Just write one or two. This is the normal. Normally, you should not see the whole thing, okay? You should not see the whole thing. If you are able to see the white of the eye under it, this is exophthalmos, okay? Notice, you can see it. You can see it. See, all of these are signs of exophthalmos because you can see the sclera under the iris. Okay, let's just Google eye, just random eye. Yeah, so you can see, you cannot see the sclera normally. See? No sclera. That is the norm. Okay, good. Of course, you need to be looking straight at you. And in that case, you will not be able to see the sclera. Well, but if he's looking up, that's different. Okay? Yep. Oh my God. Is this real picture or is it fake? I mean, each eye looks different color. Can it be in human? Yes, it is in human. If I'm not mistaken, we call it heterochromasia or heterochromasia eyes. Yeah, I think it's like the heterochromia. Yep, absolutely, yeah. So each heterochromia, each eye looks different color, has a different color. Okay. Also, these patients have a TSH receptor located at the retroorbital fat. So this TSH receptor, when it's activated by Graves' disease, because remember, in a Graves' disease, you have an IgG that is stimulatory and can activate the TSH receptor, leading to hyperproliferation of the fibrous tissue behind the eye, which will push the eye forward. If you push the eye forward, you will have yourself exophthalmosis. Okay, so they also can have this lead lag retraction. Why? Because more sympathetic stimulation of the levator bulbiferae muscle, which is at the upper eyelid. Okay, that will make the eyelid opened. Okay, that's also one more sign of hyperthyroidism. So this patient will have hyperdefecation, basically diarrhea, because of more GI motility and more appetite. However, they have really high appetite, they eat a lot. Will they gain weight because of that eating? No, because they have high increase in their metabolism. Okay, musculoskeletal stuff. So we have thyrotoxic myopathies, proximal weakness, but normal CK, in contrast with the hypothyroidism, which has high CK. Osteoporosis with increased rate of fracture. Why? Because T3 can lead to bone resorption. What does it mean, bone resorption? It means it destroys the bone to release the calcium. Okay? So when we say bone resorption, it destroys the bone to release the calcium. Also, this patient can have an abnormal uterine bleeding, gynecomastia, decreased libido, and infertility. Okay? So yeah, thyroid problema is always associated with infertility. This is why gynecologists must check these first of all. Okay, neuropsychiatric stuff. They become everything is high. Hyperactivity, restlessness, anxiety, insomnia, and a fine tremor. Why? Because they have more beta adrenergic activity. So actually the thyroxine lead to overexpression of the beta 1 and the beta 2 receptor, which is going to lead to you to have more sympathetic activity. And the reflexes is going to become much more brisk due to the same reason. So the patient are going also to have tachycardia, palpitation. So because everything is high, you have more sodium potassium ATPase, more contractility even, and you even can have atrial fibrillation because of that. And the most common cause of atrial fibrillation actually is hyperthyroidism. Okay, so can somebody tell me what is the ectopic foci in atrial fibrillation located? Well, the ectopic foci will be located near the pulmonary vein. So chest pain and systolic hypertension is due to increased number and sensitivity of the beta adrenergic receptor on the heart. So the systolic will go up, yes? Increased expression of the cardiac sarcolemmal ATPase with decreased expression with phospholamine lead to more contractility. So you will have much higher contractility of your heart, which increase your systolic blood pressure. Okay, if your systolic blood pressure goes up while your diastolic blood pressure stay the same, what will happen to you? I mean the pulse pressure. Absolutely, it will be higher. Yes, much higher. Because the pulse pressure is the difference between the two. Okay, so the TSH is going to go down if the hypothyroidism hyperthyroidism was primary from the gland itself. Also, the free T3, T4 will be up. There will be less LDL because overexpression of the LDL receptor, and more HDL, which is the good one, and everything, all of the cholesterol stuff is going to go down. Why? Because you have more LDL receptor and more absorption and degradation of the cholesterol. Okay, good. So let's take a little break now and see you guys in 10 minutes. We will do the hyper and the hypothyroidism next. So see you in 10. So let's continue with the thyroid stuff. So we have hypothyroidism and hyperthyroidism. We spoke about the generalized symptoms, and now we are going to speak about the exact problems. So hypothyroidism, what can lead to hypothyroidism? First of all, we have something called Hashimoto thyroiditis. Hashimoto thyroiditis, these patients are going to have the following. So it's an autoimmune disease. We have different types of thyroiditis. We have Hashimoto thyroiditis. We have subacute granulomatous with thyroiditis, which is used to be known as Digvar-Bain thyroiditis, and I said Bain for a reason, because this remind me that it can lead, it's the only baneful thyroiditis. So that's Digvar-Bain. And also we have radial thyroiditis. We have also, all of these thyroiditis, plural for thyroiditis. Each of these have its association. So the first of all, Hashimoto thyroiditis. It's also known as chronic autoimmune thyroiditis, the most common cause of hypothyroidism in an iodine sufficient region. Okay, why? Because if it was area that is insufficient with iodine, we can have like this something called iodine absence, or they call it an endemic goiter, especially for people living on mountains, for example. Yeah. So most common cause of hypothyroidism in an iodine sufficient region is associated with something called a human leukocyte DR3. Let me check. Is it MHC1 or MHC2? Is it going to encode it for MHC1 or MHC2? MHC2, absolutely, because 2 letters. Increased risk of a primary thyroid lymphoma, typically a diffuse large B-cell lymphoma, which is a really bad cancer actually. We are going to speak about this one in the hematology chapter. The findings: moderately enlarged, non-tender. Okay guys, look, three thyroiditis cases. 1, 2, 3. Non-tender, non-tender, tender. So the only baneful thyroiditis is the subacute granulomatous with polyangiitis, also known as Digvar-Bain. Okay? So they write, non-tender thyroid may be preceded by a transient hyperthyroid state, hashitoxicosis. Let me explain why it happens. So let's say that this is your thyroid follicle, the cells. These cells, due to the inflammation, they will rupture. When they rupture, they are going to release what? The T3 and the T4. Yes? Which is going to lead to hyperthyroidism. And after you rupture all of the follicles, what is going to happen? Hypothyroidism. So you will have a hyperthyroid state and a hypothyroid state. Okay, good. So serology. On serology, you will have an positive antithyroid peroxidase, an antimicrosomal and antithyroglobulin antibodies. Okay, so you will have an antithyroid peroxidase antibodies. Good. So the histology is going to be as follows. We have something called Hürthle cells. So these Hürthle cells are going to be something like, where are they? Something like this. To be totally fair with you, as a normal medical student, it's difficult for you to see a Hürthle cells. But the easy thing to see is a lymphoid aggregate, which is also seen in Hashimoto thyroiditis. Okay, So this is the lymphoid aggregates. These are really easy to appreciate. Yeah, this is the lymphoid aggregate. The Hertha cells, however, it's kind of difficult to see, but it's this. Let me just enlarge it for you. Okay, so you can see here the follicles. You can see here a follicle, and there is something here. This is the Hertha cells. I have, oh yeah, this is even better. So this one is the Hertha cells. Okay, so the Hertha cells, you should not actually know about it, but you must know about the lymphoid aggregates. Lymphoid aggregates are actually quite high yield for Hashimoto. Okay, so the patient is going to have lymphoid aggregate with germinal centers. So let's take a look at it. Yep, so this is Hertha cells, and basically this is going to be the lymphoid aggregates. Yeah, so lymphoid tissue. Good. So if a lady gets Hashimoto thyroiditis after her delivery, you cannot call it Hashimoto thyroiditis. Okay, you need to call it postpartum thyroiditis until 1 year after the delivery. So it's a mild self-limiting variant of Hashimoto thyroiditis arising less than 1 year after the delivery. Okay. So subacute granulomatous thyroiditis. So let's see about that. Also known as the Digvar-Bain thyroiditis, usually a self-limited disease. So the natural history is going to be a transient hyperthyroidism, a euthyroid state, which can lead basically to hypothyroidism. So basically this patient, the most important symptoms that it is painful. It's painful. I mean, if you palpate the thyroid, it will be physically painful. It often preceded by a viral infection, either respiratory or a GI type of infection. The findings include high ASR, jaw pain, very tender thyroid. So yeah, Digvar-Bain is associated with pain. In the histology, you will see granulomas formation, and yeah, so you can see here the granuloma. By the way, guys, this is not caseation. This is not caseation. This is just a colloid. In this disease, it's an autoimmune disease, so the granuloma will be non-caseating, okay? It's a non-caseating granuloma. The radial thyroiditis. Radial thyroiditis, again, it's non-tender one. The only difference in this one, that you will have a lot of fibrous tissue. So it's an invasive fibrous thyroiditis, and it's associated with something we call them the IgG4 related disease, which are known as autoimmune pancreatitis, retroperitoneal fibrosis, and a non-infectious aortitis. Okay? So, all of these diseases are associated with the serotype IgG4 related disease. If somebody has a non-infectious aortitis, keep in mind that he has a high risk of enlargement of the aorta, which can precipitate to which disease? That, think about it, the aorta aneurysm, so dilatation of the annulus, stretching of the annulus, so that will lead to a regurg, absolutely a regurg of the aorta. Hypothyroidism occurs in 1/3 of the patient. So this is the important thing, the fibrosis. Fibrosis is so bad that it's going to extend to the local structure nearby. So it can infiltrate the trachea, leading to dyspnea. The esophagus, leading to dysphagia, mimicking anaplastic tumor. So it looks like, I mean, come on, something that is infiltrating nearby tissue. This sounds like cancer, but it's not cancer. Okay, so the finding, it's a slowly enlarging, hard rock-like fixed non-tender thyroid. When we take a look at the other two, the on palpation, yes, it was non-tender, it was enlarged, but it was soft. This one is really hard. I mean, it's like a rock. When they tell you that it's really hard, start thinking radial thyroiditis. It's painless, however. So, in histology, you will see just plenty of fibrous tissue all over the place. as you can see here, you can see plenty of fibrous tissue infiltration. Okay, so there is something important to know, that this patient must be biopsied. Why? Because you need to rule out the cancer. Okay, so it's totally benign, but should you remove the thyroid if it's totally benign like this? What do you think? Should I remove the thyroid? And if yes, why? Absolutely yes, but why? Absolutely yes, because it's affecting the nearby organ, especially the airway. So you must remove it, because otherwise you might risk the patient getting airway compromisation, which can lead to his death. Okay. Okay, so really quick. Thyroiditis increase the thyroid hormone level, then decreases them. Increases them because of the destruction of the follicles, then decreases them because they are already destroyed. All of them are painless except Digvar pain. All of them are soft except Rydal. It's like a rock. And all of them have some type of infiltration. So Hashimoto thyroiditis had lymphocyte in it and lymphoid aggregates. The subacute granulomatosis with thyroiditis had a non-caseating granuloma, while the Rydal had fibrosis. Congenital hypothyroidism, also known as cretinism. It's congenital, most commonly caused by thyroid dysgenesis. So absence of the thyroid gland development due to agenesis, hypoplasia, or ectopy. Because sometimes the thyroid gland cannot be inside where it's supposed to be. It can be retrosternal, it can be lingual, it can be in other locations. Also, dyshormonogenesis, which means abnormal thyroid hormone synthesis. Okay? So, yeah, for example, a mutation in the thyroid peroxidase preventing you from making more T3 and T4, especially in an iodine sufficient area. In iodine deficient area, it becomes more common, and actually the overall most common hypothyroid cause is iodine deficiency. Okay, so let's speak a little bit about this congenital hypothyroidism. First of all, do we check for it after birth? Do we check for it every single patient, or only those with high clinical suspicions? All patients must be checked for it. That's correct. So you need to check everybody. So the finding is all the B's. The bot belly, and they also can have pale, puffy face child, which is this one. Can you see the edema of the face? And this is before the treatment. After the treatment, you can see big difference. With a protruding umbilicus, yeah, so they are associated with umbilical hernia. Write a note about that. Protruded tongue, their tongue is so big, they put it outside of their mouth. Why? Because if they keep it inside of their mouth, it's difficult to take a breath in. Okay? That reminds us of which other disease had a big tongue? That the patient keep their tongue out so they can breathe normally. Absolutely correct. Down syndrome. Down syndrome. They keep their tongue out so they can breathe normally. Okay, so also they can have poor brain development. But I have a question. Is it reversible? Yes, but it's reversible until 1 year old. Okay? After 1 year old, too late. Okay. That's why we check everybody early on. So other causes of hypothyroidism include the iodine deficiency, which is the most common cause worldwide. It can lead to something called goiter. Goiter is enlargement of the thyroid gland. It doesn't matter what is the cause, but goiter overall, it's enlargement of the gland. Iodine excess, like a Wolff Chaikoff effect. What does that mean? Well, if you give too much iodine to the patient, the gland starts to protect herself by refusing the acceptance of any iodine. Okay? And we actually do use that as a treatment in patients exposed to radiation. Okay? So we give them exogenous iodine so they will not consume the iodine from the radiation. Drugs can lead to hyperthyroidism like amiodarone and lithium. why amiodarone can lead to hypo or hyperthyroidism? Any idea? Well, basically, the amiodarone structure, if you take a look at it, it has 40% of its weight is made out of iodine, okay? So that can lead to either hypothyroid effect due to the Wolff-Chaikoff effect or hyperthyroid effect, okay? So non-thyroidal illness syndrome, also called euthyroid sick syndrome, okay? So these patients with euthyroid sick syndrome, why they have it? Well, basically they have it because they are critically ill, especially in the ICU. So they can have decrease in the T3 with sometimes normal TSH, okay? So the TSH, mostly they will give it to you normal. The T4 will be decreased or normal, mostly normal. But the main thing that will be down is the T3. This is atypical. Why? Because TSH is normally highly affected with the T3. But in the critically ill patient, it's not. So this is, we call euthyroid sick syndrome. Nice. So that was hypothyroidism. Not that bad. So the next thing we are going to speak about is the hyperthyroidism. The hyperthyroidism, the first disease we have, is known as Graves' disease. So the most common cause of hyperthyroidism. Hyperthyroidism. So what is it all about? So you have an IgG that is a stimulatory, okay? And it can stimulate the what? The TSH receptor. So an IgG can cause a transient neonatal hyperthyroidism, basically a type 2 hypersensitivity reaction. It stimulates the TSH receptor on the thyroid gland, which promote the creation of hyperthyroidism and diffuse goiter. Write a note. It doesn't matter what binds to the TSH receptor. If it activates it, you will have a goiter. If TSH binds to the gland, you will have goiter. If an IgG, activatory IgG, will bind to it, you will have a goiter. So dermal fibroblasts can lead to, dermal fibroblast activation can lead to pretibial myxedema due to deposition of glycosaminoglycans. And also orbital fibroblast, which is like so orbital fibroblasts are located behind the eye, if you remember, and they had TSH receptor, yes? So they write, activation of the T cells can lead to lymphocytic infiltration of the retroorbital fat, which increases the cytokines. Also, these cytokines include interferon gamma and also TNF-alpha. That increases the fibroblast secretion of the hydrophilic glycosaminoglycans, which will also deposit here and starts swallowing water, which also help to push the eye forward. There is something not mentioned here actually. The activation of the T cells happens because of the IgGs, okay? It's not mentioned here for some reason, I don't know why, but it happens because of the IgGs. Okay, so this patient is going to have exophthalmosis. In exophthalmosis, can you see the sclera under the iris? The answer is yes, absolutely. You can see the sclera under the iris. Okay, so increased osmotic muscle swelling, muscle inflammation, and the adipocyte count, which lead to exophthalmosis. As you can see the sclera under the iris. Often presented during the stress, like a pregnancy, and is associated with an HLA-DR3 and HLA-B8. About the HLA-B8, is it MHC1 or 2? Yep, it's MHC1, absolutely, one letter. Histology. On the histology, you will have a totally crowded follicular epithelium with a scalloped colloid. I will explain why is that. Okay, guys, do you know the Dead Sea? So let me show you a map of the Dead Sea and you will understand why I'm showing you a map of the Dead Sea. So the Dead Sea is dying. He's getting more dry, correct? So because he's getting so dry, notice what is happening into it. Can you see these lines? So these lines, why they are happening? They are happening because it's becoming more dry and dry and dry. Sorry. So it's becoming more dry and dry and dry. So because of that, it is starting to create all of these lines. Okay, so as you can see here. Good. So why this even have a relationship with the Graves' disease? It does. So Graves' disease histology. When you take a look at this Graves' disease histology, well, basically, let's take a look. You are utilizing so much MIT and DIT from the colloid that you are drying it up, and you also are using from the sides. So it's becoming utilized, yes? So you can see how whitish it's becoming from the sides. Why it's becoming whitish? Because you are consuming it. And you start having these lines in it, yeah? It's like the Dead Sea because we are consuming all of the water from it, yes? All of the colloid. So that happens in cases of hyperthyroidism. Okay, so that's a sculpt colloid, which means the whitish area around the colloid. So the next cause of the hyperthyroidism is toxic multinodular goiter, which is due to a focal patches of hyperfunctioning follicular cells. So if this is the thyroid gland, it will have multiple batches inside of it that are hyperfunctional, okay? So hyperfunctional follicular cells that are basically producing plenty of thyroid hormone. But guys, when we spoke about the Graves' disease, was it diffuse or follicular? I mean, was it all the gland was hypersecreting or it was just one point in it? All of the glands was secreting. But when we speak about toxic multinodular goiter, it's multiple small locations, okay? So if you palpate toxic multinodular goiter, you will be able to feel multiple lumps inside of it, okay? So this multiple lumps can tell you that, okay, we do have toxic multinodular goiter. So focal patches of hyperfunctioning follicular cell distended with colloid working independently of the TSH. So basically, we have plenty of thyroid hormone and they are not related to the TSH because of a mutation of the TSH receptor sometimes. But think about it. If the thyroid is producing primarily, what will happen to the TSH? I mean, yeah, I'm asking like the thyroid is producing the T3, T4, yes, in an excessive amount. So these are high. What is going to happen to the TSH? It's secreting independently of the TSH. So the TSH is going to go less, absolutely, because it's a negative feedback type of thing. Good. So increased release of T3 and T4. Hot nodules are rarely malignant, while cold nodules are malignant. What is this hot and cold nodules? Well, basically, after somebody have a nodules, you need to check it. How to check it? Well, the way we check cold and hot nodules is by Doppler scanning, okay? So what is Doppler scanning? Well, just a second. Sorry, it's either Doppler can show you that if there is a flow or not, but there is also a test called scintigraphy in which it can show you if there is an uptake of the radioactive iodine or not. So a cold nodules is dangerous. It can become cancer. While the hot nodules, which uptake the iodine, it's basically benign, okay? So hot nodules are benign. Cold nodules can be malignant. Good. Nice. So, let me just take 5 minutes break and we will come back to continue. Just 5 minutes, guys. So, We were speaking about the hyperthyroidism. The next thing I'm going to speak about is thyroid storm. It's uncommon but super serious condition that can lead to the death of the patient. That's why we study it. So the thyroid storm, it's uncommon but serious complication that occurs when hyperthyroidism is incompletely treated or untreated at all, and then significantly worsen in the setting of an acute stress. Like, let's say somebody has a Graves' disease and then he gets a really severe infection, okay? Or somebody has an initial thyroiditis and then gets a bad trauma. So it's a really stressful situation that can promote to hyperthyroidism. Also, surgery is a stressful situation. So the patient with a thyroid storm will present with an excess amount of thyroid hormone. And which arrhythmia is most likely to occur in the heart because of the thyroid hormone? The answer is atrial fibrillation. Yes. So, so this patient can have presence with agitation, delirium. Guys, is delirium reversible? Yes. So we have something called dementia and something called delirium. Dementia is a progressive. Delirium is sudden. Okay? Delirium is reversible. Dementia is irreversible, mostly. Delirium occurs quickly and resolves quickly. Dementia occurs slowly and does not reverse. Good. Okay, so delirium, fever, diarrhea. Why? Because all of these are hyperthyroid symptoms. And coma. Also tachycardia or tachyarrhythmia, which is the cause of death, like atrial fibrillation. Do you remember what atrial fibrillation can promote to? I mean, which problem is a complication of atrial fibrillation? Yep, embolism. Not an thrombus, but an embolus. Yep. So they can have thrombosis inside of the left atrium, and then it will go somewhere else, and it will form something we call thromboemboli, which is a thrombus that can travel, so it becomes an embolus. So may see increase in the LFTs. It treated with the following: propranolol, because it reduces the conversion of the T4 to T3, which is the active form. Propylthiouracil, which is an antithyroid medication. It's a thionamide. Be careful, it's highly hepatotoxic. Corticosteroid, like prednisone, because it reduces also the conversion of 4 to 3 by inhibiting the 5-deiodinase enzyme. And potassium iodide, the iodine basically, because of what? Because when you give the iodide load, it decreases the T4 secretion because of something called the Wolff-Chaikoff effect. Yep. So let's speak about Jod-Basedow phenomena. So this phenomena, it's basically people who consume iodine and then get hyperthyroidism. It's the exact opposite of Wolff-Chaikoff effect, okay? Wolff-Chaikoff effect, you give too much iodine and then you get hypothyroidism. But this one, you give iodine and you get hyperthyroidism. So when does it even occur? Well, for it to occur, you need to have a patient that at the baseline has hypoiodinism, if there is such word. So you need the thyroid gland, as you can see, the iodine to be decreased, okay? So the iodine will be decreased inside of the gland, and because the iodine will be decreased inside of the gland, if you give the iodine from the outside, it will go straight inside, make plenty of the T3, T4, yes? So, they write, iodine-induced hyperthyroidism occurs in patients with iodine deficiency and partially autonomous thyroid tissue, like an autonomous nodules, like in case of toxic multinodular goiter, is made iodine replete. So it can happen after iodine IV contrast or amiodarone use. Why amiodarone? What is special about what the name again? Jod-Basedow phenomena, the name. Yep, absolutely. So the amiodarone has a plenty of iodine in it. So as you can see in the structure of amiodarone, it has this, yeah, here you can see the iodine and the iodine. Okay, so causes of goiter. Anything that binds to the TSH receptor on the gland lead to goiter. Goiter means enlargement of the gland. So smooth diffuse enlargement can be in case of a Graves' disease, Hashimoto, thyroiditis, and iodine deficiency. Well, why iodine deficiency? When you have iodine deficiency, you have a less T3, T4, but what will be increasing? TSH. TSH will be increasing, and when the TSH will be increasing, it will bind to its receptor in the gland, making it hypertrophied. Okay, so TSH secreting pituitary adenoma. The nodular one, like toxic multinodular goiter, thyroid adenoma, thyroid cancer, and cyst. Speaking of an adenoma, so multinodular goiter, you got it, guys. So we had cold and we had hot nodules. Which one is malignant? Which one has the chance to be malignant? The cold one. Yep. Okay, so now we speak about the thyroid adenoma. It's a benign. Guys, what does the word adeno mean? Adeno. Means a gland, absolutely. And is gland epithelial tissue or connective tissue or mesenchymal tissue? It's epithelial tissue, okay? So since it is epithelial tissue, it can secrete, okay? Epithelial tissue can secrete. So benign solitary, okay, why I told you about this? Because a cancer of a gland, will it be a sarcoma or a carcinoma? Well, yeah, adenoma is a benign one, but the malignant one is going to be carcinoma, okay? Good, because it's from epithelial origin. If it was from like mesenchymal origin, like bone, cartilage, blood, stuff like that, we say sarcoma. Okay, most are non-functional, cold, can rarely cause hyperthyroidism via autonomous thyroid hormone production, while the hot one or the toxic one can. Okay, so the cold one cannot secrete, the hot one can secrete. The cold one have higher risk of being malignant. The hot one do not have the risk of being malignant. So most common histology is the follicular histology and the absence of capsular or vascular invasion, which is super important. Why? Because it helps us to differentiate between it and cancer. Okay, so cancer will have the capsular invasion, will have the vessels invasion, but in case of adenoma, it's benign, so no invasion. Speaking of the devil, let's speak about cancers. So we have thyroid cancers that has multiple types: papillary carcinoma, follicular cancer, medullary carcinoma, and anaplastic carcinoma. To start with, carcinoma, it's a cancer of epithelial cells, as you said, but is it transmitted by lymph or by blood? Well, carcinomas are normally transmitted by lymph. Sarcoma are normally transmitted by blood. Except for, there is 4 exceptions for the carcinoma in which it's not transmitted by lymph, but directly transmitted by blood. Excellent. Renal cell carcinoma is 1. What else? Choriocarcinoma, that's 2. Hepatocellular carcinoma, that's 3. And what else? Okay, let me actually repeat them because I forgot. Hepatocellular carcinoma, renal cell carcinoma, choriocarcinoma, and follicular thyroid cancer. This is why I spoke about this now. So follicular thyroid cancer is the last one. Not all thyroid cancer, only the follicular one. Okay, only the follicular. Okay, good. So thyroid cancer, typically diagnosed by a fine needle aspiration. So the idea, you stick a needle inside and you suck with the needle. So you grab some cells outside and you check for the atypia in them and the increased nuclear to cytoplasmatic ratio. Complication of surgery include hypocalcemia. Why? Because you might accidentally remove the parathyroid gland. How many parathyroid glands do you have? Yeah, the number is important actually, guys, because in the future I will be telling you about one surgery in which we removed 3.5 glands in it. So, the next thing here we have is a transection of the recurrent laryngeal nerve that can happen. And if you damage the laryngeal nerve, you can have which symptoms? Hoarseness. If you damage two recurrent laryngeal nerve, what will happen? No voice, you will become mute. Okay, so we'll have transection of the recurrent laryngeal nerve during ligation of the inferior thyroid artery, which will lead to dysphonia, which is the hoarseness. Okay, and sometimes you can have injury of the external branch, this is important actually, external branch of the superior laryngeal nerve during the ligation of the superior thyroid vascular pedicle. So, what I want you to know that there is a superior artery and an inferior artery. If you ligate the inferior artery and have a problem, this is the recurrent laryngeal nerve. It's the typical hoarseness stuff. But if you damage the superior thyroid artery, you are going to damage the superior portion of the laryngeal nerve, which can lead to a problem in the high-pitched voice. I don't know if you know these people who sing in opera, for example. So they have this higher tones of voice. So this higher tones of voice, in case of damage of this guy, the superior laryngeal nerve, if you damage that, this higher bases of voice are going to disappear. So you need to be really careful with these, especially in people who sing and do like their main work is in that. Yeah, opera singers, absolutely. Okay, so it may lead to loss of tenor, usually noticeable by professional voice users because they can use their different levels of voice, you know, because this will be only noticeable at higher bases of voice. Okay, so let's speak about papillary carcinoma. We have, yes, yeah, absolutely. So let's speak about papillary carcinoma. So it's the most common type overall, and these patients are going to have empty nuclei with central clearing, also known as the orphan Annie eyes. Guys, I will show you what do they mean by orphan Annie, but first of all, take a look at this. Can you see this clearance inside of the cell? Yeah, it's white. And basically, in this patient, they look like the orphan Annie. What is orphan Annie? Orphan Annie is an old cartoon that used to be back in the 80s, I believe. And yeah, I mean, I swear to God, when I saw a picture of it, it's scary. So yeah. Yeah, so this was a cartoon in the 80s. I mean, what the hell is wrong with people? If you see something like this now, you will, yeah. Anyway, so here you go. So if you look at her eyes, they look like the clear nuclei. Yes? So this is, yeah, the whitish stuff are orphan Annie eye. Good. So psammoma body also can be seen. Can somebody tell me, are psammoma body an example of dystrophic or metastatic calcification? Absolutely correct. So bodies. So yeah, it's dystrophic calcification. So you can see here a psammoma body. Okay, dystrophic calcification. Nice. Also, nuclear groove can be seen, and I will show you that as well. I just hope I can see it. It makes it look like a coffee bean, but wait a second. Yes, can you see it? It's this little line inside of the nucleus. That is the groove. Okay. Can you see it? It makes it look like a coffee bean. Good. So increased risk with ret mutation, and also something called BTC rearrangement, and the BRAF mutation as well, and most likely associated with childhood irradiation. Why would you irradiate a child? Chernobyl can be, but yeah, but this is rare. Also, if he had a cancer during childhood, like some, what the hell, somebody with some type of leukemia or cancers, so they can also, yeah, if you treat them with the radiation, they can get this. Okay, papillary carcinoma. It's more prevalent, palpable lymph nodes. Okay, so these patients have really good prognosis actually. The papillary carcinoma is not the worst. But if we speak about this guy, wait for it, it's going to be the worst. So the next one is follicular cancer. It's also good prognosis. It can invade the capsule. Why? Because if it does not invade the capsule, it's just a thyroid adenoma. But if it invades the capsule, it's a follicular carcinoma. It invades the thyroid capsule and the vasculature. Unlike the follicular adenoma, it has a uniform follicle. Look here, it has a hematogenous spread, is common, which is atypical for the carcinoma. Normally, carcinoma spreads by lymph. It's associated with the RAS mutation and something called the BAX and the BBAR gamma translocation. You diagnose it like the other one with fine needle aspiration, but it's impossible to distinguish it between follicular adenoma and carcinoma. Why? Because let's say that this is the tumor, and you took a fine needle aspiration from it, yes? So, if it was an adenoma, you will see follicular cells, yeah? If it was an adenocarcinoma penetrating the capsule, and you also took the specimen from here, what you will see? Also follicular cells. So fine needle aspiration cannot tell you if it's an adenoma or carcinoma. When can you know for sure if it's an adenoma or carcinoma? Yes, during pathology. So after you take out the whole gland, okay, you take out the whole gland, you check the wall. If the cancer was penetrating the capsule, then it's a carcinoma. If it was not penetrating it and it's all within the capsule, it's a adenoma. Okay, so let's take a look. Fine needle aspiration cytology may not be able to distinguish between follicular adenoma and carcinoma. Medullary cancer. So inside of our thyroid gland, we have follicular cells, and we also have something called parafollicular cells. The parafollicular cells, also known as the C cells, which are also known as the sheath cells. All of these are the same thing, and they produce calcitonin. Calcitonin is a hormone that helps move calcium from the circulation into the bone. Okay? So they write, in these patients with medullary carcinoma, they will have an excessive production of the calcitonin, which will lead to formation of sheath of polygonal cells in an amyloid stroma. What is amyloid? Okay, beta-bladed sheet, absolutely. It's a protein, beta-bladed protein, absolutely. Good. So, except the Congo red, which other stain we can, so this is the Congo red, but what other stain can we use for it? Something with fruits. Apple green birefringence, absolutely correct. The apple green birefringence. Remember that its association with the MEN syndrome, and MEN to A and MEN to B are both associated with red. Don't worry if you don't know that, because this is a whole topic that we'll be speaking about. So next we have the next cancer, um, in which it's an undifferentiated anaplastic carcinoma. Guys, when you look at this at histology, it will look like nothing. So if it looks like nothing and it can invade so many tissues around, what do you think about the prognosis? It's really bad. So let's take a look at an anaplastic means it looks like nothing. So if you look at an anaplastic thyroid cancer, let me try to trick you. Can you see the follicles here? Absolutely not. No follicles. Nothing. So you look at it and it looks like, what the hell is that? It's not, it's from the thyroid. They tell me in the question, but it does not look like a thyroid cell. Yeah? So it does not look like a thyroid cell, which means it's an anaplastic. It's mostly an older patient. It presents as a rapid enlargement of neck mass, and it will have compressive symptoms, which mean it can invade nearby structure like the trachea, leading to dyspnea. Also, it can invade the esophagus, leading to dysphagia, and it can invade the recurrent laryngeal nerve, lead to hoarseness. Now comes the difficult question. Which thyroiditis have the exact same symptoms? Because it can create fibrous tissue that can invade nearby structures. One of the thyroiditis, not cancer, thyroiditis. Digvarbain will have granulomas inside of the thyroid gland. It will not cause this. Rydell, absolutely correct. So Rydell can have fibrous tissues that can go inside of the other tissues. Can you tell me if I bulbate the Rydell thyroid gland, will it be soft or hard? It's hard as a rock. What about the anaplastic cancer? No, actually it's soft. It's going to be soft. Good. So this is a way to differentiate between them. So this one is associated with a B53 mutation. Good. So that's thyroid cancer. Nice. So let me just take a look. 2, 3, 4. Nice. So let's speak about diagnosing parathyroid diseases. So this graph, they do show it in the exam. They do show you, like on the x-axis you have the calcium, and then the y-axis you have the parathyroid hormone. So they tell you, oh, this patient had some thyroid resection, and now actually let me make my own. Please don't look at your book, just look at this, and you can see here the calcium, and here you can see the parathyroid hormone. Okay, and if we say that we have numbers here, 1, 2, 3, and 4. If we say patient had a thyroidectomy, where exactly is going, is the graph should be? Is it 1, 2, 3, or 4? Two. It's 2. Why? Because you remove the gland, yes? When you remove the gland, the parathyroid hormone is going to be less. Okay, so it's going to be either 2 or 4. So when you remove the gland, the calcium level is going to be low. So that must be the number 2. Okay, let's say somebody has cirrhosis. Sorry, not cirrhosis, but end-stage kidney disease. End-stage kidney disease. End-stage kidney disease, what will happen to your calcium? High or low? No, it's going to be low, not up. It's going to be low. Look, when you have an end-stage kidney disease, will you have an active vitamin D? So if you don't have vitamin D, what will happen to the calcium? Okay, so it must be low. So the answer must be 1 or 2. If your calcium is low, what will happen to the parathyroid hormone as a response? Yes, it will work harder. It will go up. So the answer must be 1. Absolutely. The answer must be 1. low calcium because of the vitamin D, and hyperthyroid gland. Okay, activation. Okay, good. So they write here about surgical resection and autoimmune disease destroying the parathyroid gland. So you can see the hormone will be down and the calcium will be down. In case of secondary hyperparathyroidism due to vitamin D deficiency or decreased calcium intake or chronic kidney disease, the calcium will be down, but the parathyroid gland will be over-secreting. The next case, it's somebody with parathyroid independent hypercalcemia. So he takes calcium from somewhere else. For example, guys, by the way, if we speak about somebody that is on the street and he has hypercalcemia, what is the most common cause? He's on the street, like normal human being. He comes to you to the clinic and he has hypercalcemia. No, normal human being. Perfect normal human being, not alcohol. The most common cause is primary hyperparathyroidism, okay? The most common cause. Let's say that the same person was in the hospital. He was hospitalized for anything, okay? The most common cause of hypercalcemia in people in the hospital is, starts with a C. Cancer. Okay, cancer. So inside of the hospital is cancer, outside of the hospital is hyperthyroidism. So you can see here, like hyperthyroidism, primary hyperthyroidism, both calcium and parathyroid hormone will be high due to hyperplasia, adenoma, or carcinoma. While finally we have the independent one in which excess vitamin D, the cancer, or increased calcium intake. All of these can lead to high calcium, low parathyroid gland. By the way, guys, don't forget that some cancers or granulomas or lymphomas, they can have 1-alpha hydroxidase, which is going to make more vitamin D, which is going to lead to more calcium. Also, we have another cancers that make parathyroid hormone related peptide, which is also going to lead to more hypercalcemia. The parathyroid hormone related peptide can be secreted by all of the squamous cell cancer. It doesn't matter, lung, cervix, skin, head, neck, pharynx, or oropharyngeal. All of them are going to secrete, esophagus also, going to secrete the parathyroid hormone related peptide. Okay? Nice. So let's take a little break and I will see you guys in 10 minutes. Let's start this. So we were speaking about the problem in the parathyroid gland. So there is a few other problems you need to master. For example, hypoparathyroidism. So the hypoparathyroidism, the typical one due to the resection, surgical resection or autoimmune destruction, this can happen. But there is other types that you also need to know about, which have the word pseudo in it. Okay, so we have the pseudo and the pseudo. Wait for it. So first of all, the typical one, which is destruction of the parathyroid gland. What will happen to the calcium level if you destroy the parathyroid gland? What happens to the calcium level if you destroy the parathyroid gland? The answer is that the calcium level is going down. Okay, so it's due to injury of the parathyroid gland or their blood supply, usually during the surgery, or also could be due to an autoimmune destruction or DiGeorge syndrome, in which we have total absence of like the parathyroid making, in the parathyroid gland making. So you don't have the calcium, no calcium, you will have tetany, obviously hypocalcemia, and hyperphosphatemia, because calcium and phosphate hate each other. Yes? So you are going to have Schwostig signs and the Trousseau sign. The Schwostig signs was like the tapping at the facial nerve, make your facial muscle contract, which like make you squink type of thing. While the Trousseau sign, it's like occlusion of the of course this is a Trousseau sign, not syndrome. Syndrome was in pancreatic cancer. So the Trousseau sign, it's an occlusion of the brachial artery with a blood pressure cuff, lead to carpal spasm and formation of something we call the obstetrician hand. Okay, 1 second, I will share my screen. Okay, can you see it now? Okay, excellent. So you can see here a patient who has a positive Schwostic sign. Oh, take a look. Tabbing, grimacing, tabbing, grimacing. And this guy, when you inflate the blood pressure cuff for sometimes, look, his hand becomes like the obstetrician hand. Okay, so that's the obstetrician hand. Good. So, Trousseau sign, an occlusion of the brachial artery with a blood pressure cuff leading to carpal spasm. The pseudo-hypoparathyroidism type 1A and the pseudo-hypoparathyroidism. So the first one is an autosomal dominant disease, maternally transmitted mutation and imprinted of the GNAS gene, okay? So GNAS gene is going to be mutated, and it's a which type of a mutation? It's an inactivating mutation, okay? So we are destroying the GNAS. So if GNAS is gone, the GNAS is normally coupled to the PTH receptor, okay? And basically this GNAS encodes for the GS protein, which was the secondary messenger, okay? Which eventually, if you do not have the GS protein, you will not have adenylate cyclase, okay? And I hope you remember that the PTH can function using cyclic A and B. Yes? If you remember the picture, it was the bath. So that was cyclic A and B. So now the parathyroid hormone, when he binds to its receptor, can the secondary messenger create the GS and activate the adenylate cyclase? The answer is no, he cannot. Why he cannot? Because there is no GS, because you have a GNAS inactivating mutation. So they're right. It's an autosomal dominant, maternally transmitted mutation, an imprinted GNAS, okay? So basically the parathyroid hormone is high, but he is dysfunctional, yes? So you do have the parathyroid hormone, but it's not working, so it's like you don't have it, yeah? So they're right. GNAS inactivating a mutation that encodes for the GS protein alpha subunit. So inactivation of adenylate cyclase will occur when the PTH bind to its receptor. So it's an end organ resistant to the PTH, both in the kidneys and in the bone. Think about it. If the PTH is high and he's trying to bind to its receptor but he is unable, what will happen to the level of calcium? So the level of calcium will obviously be low. What about the level of potassium? The level of potassium is going to be up. Absolutely. Right. So look, physical examination, the pseudo-hypoparathyroidism, it's a pseudo because look at the labs. The PTH is high, the calcium is low, the phosphorus is high, which means it's fake. It's not a real hypoparathyroidism. But the physical findings are existing in both pseudo-hypoparathyroidism and the pseudo-hypoparathyroidism. So what are the physical findings? The musculoskeletal abnormalities. This patient will have something called Albert hereditary osteodystrophy, which means that they have the fourth and fifth fingers to be shortened, okay? Also, they have short stature, they will be short overall, round face, and subcutaneous calcification and developmental delay. Between all of these, the most important sign is this thing. Can you see how small are their fingers, like these two? So this is just a phenotype associated with the GNAS mutation. Okay. What about the pseudo-hypoparathyroidism? Well, to understand this one, you must go back to this one. So this pathology, the pseudo-hypoparathyroidism, had two things. One, a problem in the parathyroid hormone. Two, a problem in the what? Musculoskeletal abnormalities. So in the first pathology, which is pseudo-hypoparathyroidism, so I would write just B, H, and then the second pathology, which is BB, H, pseudo hypoparathyroidism. In the first pathology, we had musculoskeletal abnormalities, which is the finger stuff, also known as the Albert hereditary osteodystrophy, and we also had the parathyroid problem. Yes? In the pseudo hypoparathyroidism, we will only have the MSK stuff. The parathyroid gland will be perfecto. The response will be perfecto. There is no problem. Okay, so it's an autosomal dominant as well, paternally transmitted mutation due to something called imprinting. I will teach you what does imprinting mean in the future. Basically, it means hypermethylation. So if you remember hypermethylation, are we activating the gene or deactivating it when we methylate it? If I methylate it, I'm deactivating it, absolutely. So it's a deactivating the gene, but without end organ resistant to the BTH due to the normally maternal allele maintaining the renal responsiveness to the BTH. So BTH responsiveness will be perfecto. And yeah, I hope it makes sense. So physical finding, it will be the same as Albert hereditary osteodystrophy. So in the pseudo hypoparathyroidism, we have the MSK problem and we do not have the BTH problem. While in the pseudo hypoparathyroidism, we have both the MSK problem, which is musculoskeletal problem, and the parathyroid problem. However, the BTH will be high. You will just have an end organ damage. So in the pseudo hypoparathyroidism, you will have a normal BTH, normal calcium, normal BO4 phosphate, because it's unrelated to the whole thing. Okay, let's take a look at the next thing. So the next thing, let's see. Okay, so the next thing is speaking about the lab values in hypocalcemia. So in hypocalcemia, when you have vitamin D deficiency, calcium will be low, phosphorus will be low, because both of them are absorbed with the help of vitamin D from the intestine. As a response, the BTH will be up. Hypoparathyroidism, the BTH will be low. BTH normally used to trash the phosphorus from the proximal convoluted tubule. So he cannot trash it anymore, so it will be high. The calcium will be low because he cannot reabsorb it from the DCT anymore. Okay, so secondary hyperparathyroidism, which means chronic kidney disease, for example. So in chronic kidney disease, you have low calcium, and that increases the BTH, which is going to basically do what? So you have vitamin D deficiency, which is going to basically try to decrease vitamin D deficiency. So your calcium is going down. Your parathyroid hormone will be trying to respond for that. So your parathyroid hormone will go up. What about the phosphorus? Why it's high? Because the kidney itself is damaged and the BCT itself is damaged, so it cannot trash anything. So it will be high. So if the BCT is unable to trash it, it will be high. Pseudo hypoparathyroidism. Okay, so we said the BTH will actually be high, but it's dysfunctional. So it's the same as it being low, as you can see. So phosphorus will be high, calcium will be low. Hyperphosphatemia, that will basically chelate the calcium, which will decrease it, and thus the BTH will go up. Okay, so that was all of them. Now let's take a look. Let me just check the timing. Okay, so here we have the last thing I want to speak about, which is hyperparathyroidism. We have primary hyperparathyroidism, secondary, and tertiary. The primary one, usually due to parathyroid adenoma or hyperplasia. So it's a problem in the gland itself. It leads to oversecretion of the calcium and hypercalciuria, which can precipitate to kidney stones. Also polyuria. Why? Because it keeps trying to kick out calcium. And because you have so much calcium inside of your body, you are going to have less phosphate because it chelates it. So that will increase your BTH and the alkaline phosphatase as a responsive mechanism. Why? The alkaline phosphatase always gets activated when you have an activation of the osteoblastic cells of the bone. And remember, you must activate the osteoblast for the sake of activating the osteoclast, for the sake of getting calcium out of the bone, which is something that the parathyroid hormone does. Also, you will have more urinary cyclic AMP. Why? Because the parathyroid hormone works via cyclic AMP. It's most likely to be asymptomatic but may present with bone pain, weakness, or constipation because of the hypercalcemia. Okay? Also, the patient can have abdominal and flank pain because of the stones formation and even acute pancreatitis because of the calcification. Neuropsychiatric disturbances can occur as psychiatric overtones can occur. So, osteitis fibrosa cystica, cystic bone species will be filled with brown fibrous tissue, and it will be like this, and it will be super painful for the patient. This is basically happening. Why? Because of the dissolving of the bone and deposition of blood in its location. So let's see what they write. Cystic bone species filled with a brown fibrous tissue, a brown tumor consisting of osteoclastic cells and deposition of hemosiderin from the hemorrhage. So you will have hemorrhage inside of the bone because you broke it down. Basically, you remove. Let's say that this is the bone. You removed one portion of it to make calcium. Yes. So in that place you will have hemorrhage, which have blood in it. The blood will be converted to hemosiderin, which is brown. So it can lead to bone pain, and due to increased parathyroid hormone, it happens classically associated with a primary hyperparathyroidism, but also seen with the secondary one. So the patient are going to have stone in the kidneys, thrones, bones, groans, and psychiatric overtones. So they can have the abdominal and the flank pain because of the kidney stones and the acute pancreatitis, and the psychiatric overtones because of the psychiatric overtones. Basically, we have calcium channels inside of our brain as well. If you activate them, hyperactivate them, you will be irritable. You will become irritable. Secondary hyperparathyroidism, it means the end organ is damaged. That means you will have less calcium, like from the kidney, and thus your parathyroid gland will be oversecretion. So it's a secondary hyperplasia due to low calcium absorption or high phosphorus. It's most often due to a chronic kidney disease, which lead to hypovitaminosis D and hyperphosphatemia, which can lead to low calcium. Okay, so the patient is going to have hypocalcemia, hyperphosphatemia in chronic kidney disease, but if it was any other cause, it will be hypophosphatemia. Why in the kidney disease they have hyperphosphatemia? Due to the failure of the BCT to trash the phosphate. Okay, so this patient, because of the parathyroid hormone, it will lead to activation of the osteoblast to activate the osteoclast, and that will increase the ALB. Okay, also the BTH will be high, which is the main pathology. Okay, so that's secondary hyperparathyroidism. Okay, if you have secondary hyperparathyroidism for a really long time, you are going to get tertiary hyperparathyroidism. What does that mean? Let's say you correct the patient calcium after some times because you produce so much BTH. Is the parathyroid hormone going to stop secreting in tertiary hyperparathyroidism? The answer is no. So you have corrected the calcium, but regardless, now the parathyroid gland became crazy, and she's like, I'm autonomous and I will keep secreting even if you fix it. Refractory autonomous hyperparathyroidism resulting from chronic kidney disease. So the patient initially have chronic kidney disease, have hypocalcemia, and gets hyperparathyroidism. After some times, he fixes the calcium level, but the parathyroid gland is not going to step back. It keeps secreting so much. So renal osteodystrophy can occur, which like from renal disease, you can have secondary and tertiary hyperparathyroidism, which basically can lead to bone lesion because so much parathyroid gland is being produced, which destroy the bone for the sake of increasing the calcium inside of the circulation. The last pathology for the day is something called familial hypocalciuric hypercalcemia. It's a defect in the G-coupled calcium sensing receptors in multiple tissue. So basically, the sensor of the calcium is messed up, especially at the parathyroid gland and the kidney. Okay, so higher than normal calcium level are required to suppress the BTH. So it's kind of difficult to suppress the BTH right now. So the BTH is going to be what? Over-secreted. Going to be up. Somebody say he cannot hear me. Is that a problem with everybody? Can you hear me, guys? Okay, let me repeat this pathology then. So familial hypocalciuric hypercalcemia, it's a problem in the receptor on the gland, basically. And this receptor is G coupled, okay? So the calcium, when he binds here, the parathyroid gland knows, like, oh, calcium, I should stop secreting, yes? But the problem is here that you need so much calcium to activate the receptor, okay? So defect in the G-coupled calcium sensing receptor in multiple tissue like the parathyroid gland or the kidneys, which lead to higher than usual calcium level will be required to suppress the PTH. So there will be an excessive calcium reabsorption. Why? Because you have so much PTH. And mild hypercalcemia and hypocalciuria. Why? Because the PTH will be high and that will consistently reabsorb the calcium. So you will have hypercalcemia, hypocalciuria, and high PTH. This is familial hypocalciuric hypercalcemia. Okay, guys, so that's it for today. We have discussed today hypo and hyperthyroidism, hypothyroidism alone, thyroid cancer, diagnosing of the parathyroid diseases, and the hypoparathyroidism and the pseudo-hypoparathyroidism and the hyperparathyroidism and the familial hypocalciuric hypercalcemia. So hopefully tomorrow we'll be speaking about diabetes, all of its type, Cushing syndrome, and aldosteronism, and everything until we reach the pharmacology. Yeah, so hopefully by tomorrow we'll be done with the pathology of the endocrinology, and the day after tomorrow, but I don't know, according to the schedule, the next working day, we will do the pharmacology and be done with the endocrinology as promised. So see you guys tomorrow. Goodbye, everybody.